Hello friends, today we are going to discuss about evidence-based management of the stroke. So first we'll start with definition. In 1970, the WHO defined stroke as rapidly developed clinical sign of focal disturbance of cerebral function which are lasting for more than 24 hours or leading to death with no apparent cause other than vascular origin. Now we'll see what are the major risk factors for stroke. Well documented modifiable risk factors are hypertension, diabetes mellitus, dyslipidemia, obesity, body fat distribution, physical inactivity, and tobacco use. Then structured cardiac disease such as rheumatic valve disease, atrial fibrillation, sickle cell disease, carotid artery stenosis, excessive alcohol consumption, unhealthy diet and nutrition. Less modifiable, less well-documented modifiable risk factors are migraine, metabolic syndrome, drug abuse, obstructive sleep apnea, hyperhomocysteemia, hypercoagulability, elevated lipoprotein, inflammation and infection. Then regarding pathophysiology, the pathophysiology of the stroke is thrombotic, embolic and hypoperfusion. So acute intracranial vascular disorder, it can be categorized as being due to large vessel thrombosis, small vessel thrombosis, and cardioembolism. So large vessel atherosclerotic occlusion is caused by atherosclerosis in carotid and vertebrobasilar artery, and it includes the intracranial atherosclerosis. So large vessel disease is the most common cause. The pattern and severity of neurological deficit depend upon the arterial territory, incompleteness of occlusion, and extent of collateral flow. While small vessel arterial occlusion is frequently due to lipohydrosis of uh, lenticulostriatal arteries and basilar penetrators, which results into the small area of cerebral infarction, which is known as lacuna. If lacunae occurs into the internal capsule, thalamus, basis fontes, substantial neurological deficit may occur even with the small lesion. So most common lacunar syndromes are pure motor hemiparesis, pure sensory loss, ataxic hemiparesis, dysarthria clumsy hand syndrome. Then next is cardioembolic stroke. Cardioembolic stroke is with maximum deficit at onset, although small minority may have stuttering clinical course. So diagnosis may be difficult when patient has coexisting cerebral atherosclerotic stenosis, since as many as one-third of the patient with cardioembolic source have another potential explanation for their stroke. So these are the common causes of embolism, like non-valvular atrial fibrillation, acute atrial wall infarction, ventricular aneurysm and dyskinetic segment, rheumatic valvular disease, prosthetic cardiac valve, right to left shunt, bacterial endocarditis. And less common causes are mitral valve prolapse, cardiomyopathy, bicuspid aortic valve, atrial myxoma, non-bacterial endocarditis, mitral annular calcification, idiopathic hypertrophic subaortic stenosis. So non-valvular embolic sources with atrial fibrillation are associated with annular stroke risk between 2.2% to 15% depending on the associated risk factor. Transmyocardial infarction, atrial fibrillation, and mechanical valves are associated with high risk, where risk is lower for patients with a biprosthetic valve. Patent right to left cardiac shunt may have been recognized by contrast echocardiography with increasing frequency among younger patients with stroke. So, in the absence of hypercoagulable state or atrial septal aneurysm, a patent foramen ovale is not considered significant risk factor for cardioembolic stroke, with up to 25% of healthy population noted to have patent foramen ovale. The aggregated category of other known etiology include rarer causes distinct from other categories. These include traumatic and spontaneous extracranial intracranial arterial dissection, which is an important cause of stroke under age of 50 years. Thrombophilias, whether congenital or acquired, are more likely to impact venous system, but may be unusual cause of artery occlusion, including ischemic stroke. Then border zone infarction is caused by a diminished cerebral blood flow resulting from cardiac arrest or systemic hypotension, often associated with cerebral arterial stenosis, resulting in focal infarction and deficit occurring in well-described pattern of end arterial distribution between two major arteries. So for carotid circulation, border zone infarct occur between the distribution of middle cerebral artery, either anterior and posterior cerebral artery. Stroke of undermined etiology or cryptogenic stroke is diagnosed after full evaluation of other known causes has been unrevealed. And this entity is associated with better outcome than the stroke of other categories, and it requires treating physician to do comprehensive evaluation when cause of stroke is not apparent. A subset of cryptogenic stroke include those in patients with embolic stroke of undetermined source. These patients typically have the pattern of infarction consistent with embolism and have completed an evaluation to exclude other causes of ischemic stroke. Then the clinical feature. So those who are presented with the lacunar stroke, they will be presenting with the transient ischemic attack shortly before stroke. It can occur in cluster, more stereotypical as compared to the larger vessel TI. It occurs insidiously, gradually, and have stammering course. The lesions are small but may be symptomatic if they involve region like full of high density of axon having multiple extension, such as cerebral peduncle and brainstem. Presentation may vary, it can present as pure motor stroke, pure sensory stroke, sensory motor stroke, ataxic hemiparesis, dysarthria clumsy hand syndrome. So, systemic embolism, the presence of pre-existing organic cardiovascular disease like mechanical valve disease, cardiac valve dysfunction, atrial fibrillation, left atrial ventricular thrombus, dilated cardiomyopathy, recent MI, left ventricular aneurysm, sixth sinus syndrome, infective endocarditis, or atrial myxome. It has sudden onset with maximum severity at onset. It can usually occur in the awakened state and during activity. So recurrent TIA can be seen involving various anatomical areas. Now the large artery thrombosis. This may occur by one of the three mechanisms. Post-stenotic perfusion deficit, sudden occlusion by atherothrombosis, arterial embolism. So history will be, and in this time, the history, and when there is a large vessel occlusion, the history will be suggestive of risk factors like hypertension, diabetes, obesity, smoking, male sex. There will be the history of frequent transient ischemic attacks. Onset is often during sleep or atherothrombotic stroke during activity. A gradual progression or stepwise course over a minute to hours is characteristic. Then dissection of the cervical artery. So the risk factors will be recent trauma, previous infection, some connective tissue abnormality. The characteristic clinical feature is focal neurological syndrome in combination with unilateral headache, neck pain, pulsatile tinnitus, ipsilateral Horner syndrome in case of internal carotid dissection, artery dissection. Now we'll see what are the stroke mimics. So stroke mimics are the condition which mimic as a stroke. First is hemorrhagic stroke, then brain abscess can present with the focal neurological deficit. Hypoglycemia is the important stroke mimic, so it is very necessary to check the blood sugar level before we are labeling that person as a stroke patient. Then sometimes lithium toxicity is presenting with confusion, ataxia, slurring of speech. Then patient with hypertensive encephalopathy may present with the cerebral edema, seizure, cortical blindness, subarachnoid hemorrhage, neoplasm, then sagittal venous thrombosis, multiple sclerosis, TOTS paralysis, migraine, meningitis, vasculitis, hysteria, and other psychiatric illness. So to rule out this condition, we should know what are the favoring features which are from which we can say the patient is having stroke. Like there will be the absence of headache or vomiting. The onset will be rapid. Then the presence of cardiovascular disease will be there, like chronic hypertension, atrial fibrillation, recent MI, valvular heart disease. presence of peripheral vascular disease, which is suggestive from the clinical findings like murmur, carotid blue, atrial fibrillation. Then there are some features which are diagnostic of hemorrhagic stroke, like presence of headache, vomiting, absence of neurological deficit at onset. Then altered mental status, seizure, which are very commonly seen in hemorrhagic stroke. Progression of neurological deficit over few hours, absence of early improvement, and severe uncontrolled hypertension and cocaine use. So to identify the stroke correctly, there are two score systems like BFAST. Initially, we are using it as fast. We are calling the score as a fast score, but now it is renamed as BFAST to include the features of the posterior circulatory stroke, where B is balance, E is blurring of vision, F is face, deviation of the face, A is arm drift, S is slurring of speech. And when all these features are there, then T is the time to call ambulance. Then the next scoring system is NIHHS, that is National Institute of Health Stroke Scale, which can be used in initial assessment as a clinical tool to quantify the severity of the stroke. It is used to evaluate and document neurological status in stroke patients. It has been validated for predicting lesion site and measure the stroke severity. And it has been shown to be predictor of both short-term and long-term outcome of the stroke patient. It also helps in choosing the appropriate treatment modality. So it has 11 different components, and each component has maximum score of 4. Total score is calculated by adding the number. So 42 is the highest. But it has certain limitations, like it is difficult to implement in patient with the prior neurological deficit, endotracheal intubation, and language barrier. So these are the component of NIHHS score, like level of consciousness, horizontal eye movement, visual field test, facial palsy, motor arm, motor leg. So we have to examine both left and right. Then presence of limb ataxia, sensory impairment, language impairment, speech impairment, extinction and inattention. So the total score is ranging from the 0 to 42. So based on this, we can categorize the severity of the score. So if the NIHHS score is 0, that means there is no stroke. If NIHHS score is between 1 to 4, that means minor stroke. Moderate score includes the NIHHS score from the 5 to 15. Moderate to severe score includes the NIHHS score from 16 to 20. Severe score from 21 to 42. Now the role of imaging. Neuroimaging like CT and MRI is helpful in the diagnosis of the stroke. Door to CT imaging door to CT imaging time should be less than or equal to 20. So non-enhanced CT definitely exclude the parenchymal hemorrhage and can be used to assess other exclusion criteria for intravenous recombinant tissue plasminogen activator, like extensive area of hypoattenuation, and it may demonstrate subtle visible parenchymal damage within 3 hours. So NECT is correctly able to identify most causes of intracranial bleeding and can help to diagnose other causes of neurological symptoms such as brain tumor. So CT will be unable to pick up accurate infarct and small posterior foci lesion. It is also not useful when patient has small cortical and subcortical infarction. So it is the common modality used in acute ischemic stroke imaging due to easy availability, faster scan time, and easy interpretation. Early signs of stroke on CT are hyperdense artery sign, dot sign, insular ribbon sign, basal ganglia asymmetry, loss of gray-white differentiation, and low attenuation in the cortex. Then the next is Alberta Stroke Program Early CT Score. That is ASPECT score. ASPECT score is the 10-point CT scan score used in patients with middle cerebral artery stroke. The segmental assessment of MCA area is made and the 1 point is deducted from the initial score of 10 for every region involved. That is caudate, putamen, internal capsule, and insular cortex. So in this M1 area is corresponding to the anterior MCA cortex, which corresponds to the frontal operculum. M2 is the MCA cortex area, which is lateral to the insular ribbon. M3 is the posterior MCA cortex, which corresponds to the posterior temporal lobe. M4 is the anterior MCA territory immediately superior to M1. M5 is the lateral MCA territory immediately superior to M2. And M6 is the posterior MCA territory immediately superior to M3. So, same like anterior circulation, PC aspect is the 10-point scale where the points are lost from for each region affected. So in that area involved is thalamus, occipital lobe, midbrain, pons, and cerebral hemisphere. So the aspect score is less than or equal to 7. That means the worst functional outcome at 3 months. So according to study, if the aspect score is 8 and if we thrombolize that patient, then the outcome is not, then it is not associated with the good clinical outcome. CT tomography perfusion imaging is the CT-based modality, which utilizes the quantitative analysis of kinetics of bolus of CT contrast passing through brain to obtain perfusion map of the brain and predicts whether the tissue will die or survive. Then the next is MRI. MRI can help in define the subgroup of the stroke patient which may benefit from thrombolysis or mechanical thromboaspiration. MRI with the gradient echo sequence is equivalent to the CT to detect acute intracerebral bleed. MRI protocol combining T1, T2 imaging with diffusion weighted imaging and perfusion weighted imaging and the gradient echo can reliably diagnose both intracerebral bleed as well as acute ischemic stroke. So DWI is currently most sensitive and specific imaging technique for diagnosis of acute ischemic infarct, very early. It allows the identification of the lesion size, site, and age. So DWI can detect relatively small cortical lesions, small deep and subcortical lesions, including those in the brainstem, cerebellum area, which are often poorly and not visualized with standard MRI sequences and any CT scan technique. So DWI can identify the subclinical satellite ischemic lesion that provide information on the stroke mechanism. Diffusion weighted imaging in combination with the ADC can differentiate between vasogenic and cytotoxic edema. So in acute ischemic stroke, cytotoxic edema is seen as hyperintense on DWI and hypointense on ADC, while vasogenic edema are hyperintense in both in DWI and ADC. So diffusion weighted imaging denotes the presence of ischemic injury, while perfusion weighted measures the perfusion of brain tissue with contrast agent. So diffusion perfusion mismatch can help identify ischemic penumbra, which may represent area at risk of infarction and possibility of salvage. So diffusion perfusion mismatch correlate well with the initial NIHSS score and it may predict early neurological deterioration. Now we'll see what are the advantage and disadvantage of CT and MRI. So advantage of MRI is this diffusion weighted imaging is highly sensitive and specific in diagnosing acute ischemic stroke. It has ability to distinguish acute small cortical, small deep and posterior fossa infarct. It has ability to distinguish the acute from chronic ischemic. It can identify subclinical satellite ischemic lesion that provide information on the stroke mechanism. It avoids the exposure to ionizing radiation and it has greater spatial resolution. GRE are as good as CT to detect intraparenchymal bleed. Now the limitation of MRI is cost, relatively limited availability of the test, relatively long duration of the test, increased vulnerability to the motion artifact, and contraindications like claustrophobia, cardiac pacemaker, patient confusion, and metering. Now, advantage of CT scan over MRI is detection of the bleeding, less time consuming, cost, widespread availability, and less info. So we can plan other investigations like blood glucose, oxygenation saturation, electrolyte, platelet count, marker of ischemia, prothrombin time, INR, APTT, ECG, CT, carotid Doppler, 2D echo. In selected patient, we can plan thrombin time, heparin clotting time, heparin function test, toxicology screening, blood alcohol level, pregnancy test, ABG, chest radiograph, lumbar puncture, and EEG. Now we'll see how to treat patient. So for treatment, two methods are available, that is thrombolysis and endovascular therapy. For thrombolysis, two agents are there, tenecteplase and alteplase. So out of that, alteplase is FDA approved, and mechanism of action is endogenous tissue plasminogen activator and recombinant alteplase will break down fibrin in thrombi by cleaving fibrin-bound plasminogen to plasmin, which is a proteolytic enzyme involved in proteolysis. This alteplase has very short half-life, that is 4 to 5 minutes. Hence, alteplase should be administered in bolus and infusion form. So dose of the tenecteplase is 0.25 mg per kg. Maximum dose that we can administer is 25 mg. It is administered over 5 seconds. The dose of alteplase is 0.9 mg per kg. Maximum dose that we can be administered is 90 mg. Now the indication of thrombolysis. So the indication of so in context of this, one trial was published in 1995, that is NEEDS trial. So according to this trial, we can thrombolize the patient who presented to us in first 3 hours if they are following criteria. If age is more than or equal to 18 years and less than 80 years. Then in mild disabling stroke, the class of recommendation 1 and level of evidence is B. Severe stroke, despite bleeding risk is high, still the class of recommendation of this is 1 and level of evidence is A. Now, after that, ICAS trial was published. So according to this trial, we can extend this window from 3 to 4.5 hours. But from 3 to 4.5 hours, there are specific indication to thrombolize the patient. So in that indication, this indication includes if the age of patient is less than or equal to 80 years, no history of diabetes mellitus, no history of stroke. There should not be any history of any oral anticoagulant. NIHS score should be less than 25 and without imaging evidence of ischemic injury involving more than 1/3 of MCA territory. So then another trial was published in 2018, that is Wake Up trial. So according to this trial, we can thrombolize the patient who presented to us out of window period. That means if they are presenting to us more than for more than 4.5 hours, then also we can thrombolize the patient, provided so that or if the patient's or if the patient last known time is if it is not known, then also we can go for the thrombolysis. But what they have done in this is uh, the patient who presented to them with the wake up stroke or with the unknown time of onset, they have undergone the MRI with the diffusion weighted imaging and the flare. If the MRI is, if the stroke is visible in the diffusion weighted imaging but not in the flare, that may they have thrombolized this patient. And if it is the picture, that means if the infarct is visible in the diffusion weighted imaging but not in the flare, then this window period is within the 4.5 hours and they thrombolize those patients. And what they have found is there was a significant better functional outcome, but numerically more intracranial hemorrhage than the placebo. Then next, the extent trial was published. And in that, they which further extended this window period from 4.9 to 4.5 to 9 hours. So according to this trial, even if the patient presented to us if the patient presented to ER or any ICU out of window period, and if we did the MRI of this patient, and still the infarct is visible into the diffusion weighted imaging, but not in the flare, then still we can thrombolize the patient. So when they have, so the conclusion of this conclusion of this trial was there was no or minor neurological deficit, but there was symptomatic intracranial hemorrhage was high. So we'll see now what are the contraindication of the stroke. So the time of onset is more than 3 to 4.5 hours, but yeah, we can still thrombolyze if there is a mismatch between the diffusion method and flare. So still that area is salvageable, and we can go for with the thrombolysis. If CT is suggestive of the acute intracranial hemorrhage, that is a definitive contraindication. If CT showing the extensive area of the hypoperfusion, if ischemic stroke is within 3 months, severe head trauma within past 3 months, intracranial intraspinal injury within 3 months, history of intracranial hemorrhage, clinical feature consistent with the subarachnoid hemorrhage, presence of structural intragastrointestinal malignancy and GI bleed, then patient with the coagulopathy defined as platelet less than 1 lakh, INR more than 1.5, APTT more than 40 seconds, and PT more than 15 seconds. Patients who have received therapeutic low molecular weight heparin within 24 hours, current use of direct thrombin inhibitor and direct factor 10A inhibitor or glycoprotein 2B3A inhibitors, clinical feature consistent of infective endocarditis, aortic arch dissection, intraaxial intracranial neoplasm. Then the next precaution that we need to take while thrombolizing, before thrombolizing is before proceeding with the thrombolysis, the patient's blood pressure should be less than 185 by 110. If it is more than 185 by 110, then we can treat that blood pressure with either labetalol, nicardipine, and clevidipine. So labetalol dose is 10 to 20 mg IV over 1 to 2 minutes. Nicardipine 5 mg per hour. We can titrate it by 2.5 mg every per hour by every 5 to 15 minutes. Maximum dose that we can use is 15 mg per hour. Clevidipine is 1 to 2 mg per hour, titrated by doubling dose every 2 to 5 minutes until desired BP is reached, and the maximum dose is 21 mg per hour. Then we can use other agents also like hydralazine and then enalapril may be considered when inappropriate, if when appropriate, and if BP is not maintained at or below 185 by 110. So what they want to say is, despite giving all medication, even if our BP is not controlled, then do not proceed with the thrombolysis. So and despite giving all medicines, even still our BP is high, then we can explore the option of giving sodium nitroprusside. So during thrombolysis procedure, we need to monitor the BP very strictly. So measure the BP every 15 minutes for 2 hours from the start of recombinant tissue plasminogen activator, every 30 minutes for 6 hours, and then every hour for 16 minutes. For 60 hours, sorry. So if BP is still higher than 185 and diastolic is more, then we can give the labetalol 10 mg IV followed by continuous infusion of 2 to 8 mg per minute. Nicardipine 5 mg per hour. Then and BP is not controlled, go for sodium nitrate. Then the complication of thrombolysis. If we are giving thrombolysis, then we need to worry. Then we need to be aware of this combination. Like sometimes there are the intracranial bleed. So if you find the patient GCS is dropping or patient has the focal neurological deficit is worsening, then and if you are suspecting the intracranial hemorrhage, stop the altiplase there only, go for the CT, send the CBC, PT, APTT, fibrinogen level, then administered cryoprecipitate. That is 10 unit infused over 10 to 30 minutes, administered additional dose of fibrinogen, administered additional dose if the fibrinogen levels are less than 150. We can also go with the tranexamic acid, that is 1000 mg IV infused over 10 minutes, or gamma or epsilon aminocaprylic acid, that is 4 to 5 gram over 1 hour followed by 1 gram IV until bleeding is controlled. Then immediately sought for the hematology and neurosurgery consultation. If the patient presents develop angioedema, then go for endotracheal intubation. If edema involving larynx, palate, the floor of mouth, oropharynx with rapid progression, then it has a high risk of requiring intubation. Go for awake fiber optic intubation if optimal. Nasal tracheal intubation may be required, but it possesses the risk of epistaxis after ultimates. Cricothyrotomy may be needed in rare conditions. So in that case, discontinue IV alteplase infusion and hold AC inhibitors. Administered IV methylprednisolone 125 mg. Administered diphenhydramine 50 mg. Administered ranitidine 50 mg IV or famotidine 20 mg. If there is further increase in angioedema, we can administer epinephrine, that is 0.5 ml subcute or nebulizer 0.5. Then the next option is mechanical thrombectomy. Mechanical thrombectomy is the reperfusion modality used in patients with acute ischemic stroke due to large artery occlusion in anterior circulation. It has been proven to be beneficial if used within 24 hours of symptom onset or with or without using alteplase in 4.5 hours of window period. So mechanical thrombectomy is indicated and it should be initiated as early as possible without waiting for response to tissue uh, intravenous recombinant tissue plasminogen activity. So how it is working? So when large vessel occlusion is occurs, deeper structures are supplied by vascular territory that lack collateral blood supply will infarct first. So the area of the brain tissue with irreversible ischemic damage are known as ischemic core. However, the part of vascular territory surviving on collateral flow is known as ischemic penumbra. And this area of the potentially salvageable brain tissue demonstrates reversible ischemia if reperfusion is achieved. So the quality of collateral flow was the predominant factor influencing infarct growth. Now the indication of mechanical thrombectomy. Mechanical thrombectomy with the stent retrieval. If pre-stroke MRS score is between 0 to 1. Occlusion of internal carotid artery and MCA segment 1. If age is more than 18. If NIHS score is more than or equal to 6, aspect score is 6, and the treatment can be initiated within 6 hours from the symptom. Now, in context of mechanical thrombectomy, the two trials are published, Down trial and Diffuse trial, in year of 2018. So according to the Down trial, the eligibility criteria was occlusion of intracranial internal carotid artery, the first segment of middle cerebral artery, or both. Then they have included the patient's criteria was age more than 18 years and had NIHS score of more than 10 or higher, uh, with infarct volume of less than 20 ml. Then group B, in which they included comparatively younger patient of less than 18 years of age, NIHS score of 10 or higher, and infarct volume of less than 31. Then group C is the younger patient of 18 years of age, had NIHS score of 20 or higher, and infarct volume of 31 or less than 50. The infarct volume was assessed with the use of diffusion weighted MRI or perfusion CT and was measured with the automated software. An interval between the time and the patient was last known to be well under randomization of the 6 to 24 hours. The pre-stroke score of 0 or 1 on modified Ranskin scale, and no evidence of intracranial hemorrhage on the CT or MRI, and there was no evidence of infarct involving more than one-third of territory of middle cerebral artery on CT or MRI at baseline. Then the inclusion criteria of the diffuse trial. The patient were enrolled if they meet the clinical and imaging eligibility requirement and could undergo initiation of endovascular therapy between 6 to 16 years after the time that they had last known to be well. including patients were eligible if they had infarct volume of less than 70 ml, ratio of volume of ischemic tissue to initial infarct volume of 1.8 or more, and absolute volume of potentially reversible ischemia of 15 ml or more. So patients were required to have occlusion of cervical and intracranial internal carotid artery or proximal middle cerebral artery on CT, angio, and MRI. So these are the trial which was published in the context of mechanical thrombectomy, that is Mr. Green trial, Re Revascat trial, Escape trial, Sweet Frame trial, and Extend 1A trial. So according to this trial, the successful recanalization was achieved in all the trials, but there was no mortality difference between the mechanical thrombectomy and best medical management. Posterior circulation, acute stroke prognosis. Early cities was created and subsequent validation to prognosticate for basilar artery occlusion. So favorable functional outcome was predominantly seen in patients with aspect score of more than or equal to 8. Owing to the clinical importance of brainstem ischemia, alternative scoring known as Pons midbrain index has been developed. So in the context of posterior circulation stroke, these trials was published, that is basic trial, base trial, and recently attention in the Beauche trial was published. So in this also the successful recanalization was achieved, but the mortality was around 30% in all the trials. So thrombolysis during mechanical thrombectomy. Intraarterial thrombolysis initiated within 6 hours of the stroke onset in carefully selected patients who have contraindication for intravenous alteplase might be considered. So in 2020, there was one trial was published, that is direct entry trial. So according to this was endovascular thrombectomy with or without intravenous alteplase. So according to this trial, in Chinese, the conclusion of this trial, in Chinese patient with acute ischemic stroke from large vessel occlusion, endovascular thrombectomy alone was non-inferior with regard to functional outcome within 20% margin of confidence to endovascular thrombectomy preceded by intravenous alteplase administered within 4.5 hours after symptoms. So there was no difference when they have used the intravenous alteplase or when they have without or when patient has undergone endovascular therapy without alteplase. Then Extend A trial was published in which they compared the effectiveness of intravenous tenecteplase dose on cerebral reperfusion before thrombectomy in patients with large vessel occlusion. So in this, the conclusion of this trial was among patients with large vessel occlusion ischemic stroke, a dose of 0.4 mg per kg was compared to the 0.25 mg per kg of tenecteplase, and that did not significantly improve cerebral reperfusion prior to the endovascular thrombectomy. So the findings suggested that 0.4 mg per kg of tenecteplase doesn't have any advantage over 0.25 mg per kg of tenecteplase with large vessel occlusion ischemic stroke. Then in recently the timeless trial was published, and according to this trial, tenecteplase therapy that was initiated 4.5 to 24 hours after stroke onset with occlusion of middle cerebral artery and internal carotid artery, most of whom undergone endovascular thrombectomy, did not result in better clinical outcome than those with placebo. But the incidence of symptomatic intracerebral hemorrhage was similar in both groups. Then next trial was published, that is Trace 3 trial. So according to this trial, this trial will involve the Chinese patient with ischemic stroke due to large vessel occlusion, and most of whom did not undergo endovascular thrombectomy with tenecteplase administered within 4.5 to 24 hours after stroke onset, resulted in less disability and similar survival as compared to standard medical treatment, and the incidence of symptomatic intracranial hemorrhage appear to be high. Then the next was the decompressive craniotomy. In patient with less than 60 years of age, what are the indication of decompressive craniotomy? In patient with less than or equal to 60 years of age who deteriorate within 48 hours from brain swelling associated with unilateral MC infarction despite medical therapy, decompressive craniotomy with dural expansion is recommended. So in the patient with the less than 60 years of age, this decompressive craniotomy has a class of recommendation 2A, level of evidence A. But if the patient is more than 60 years, then this decompressive craniotomy has class of recommendation 2B, level of evidence B. Then Destiny trial was published in 2014 to give the direction when to perform hemicraniotomy. So when hemicraniotomy was performed in extensive middle cerebral artery stroke, the conclusion of this trial was hemicraniotomy increases survival without severe disability among patients 61 years of age or older with malignant middle cerebral artery infarction. And the majority of survival requires assistance with most bodily needs. Then the indication of surgical therapy in cerebral infarction. Ventriculostomy is recommended in the treatment of obstructive hydrocephalus after cerebral infarction. Decompressive suboccipital craniotomy with dural expansion should be performed in patients with cerebral infarction causing neurological deterioration from brainstem compression despite maximal medical therapy when safe obstructive hydrocephalus should be treated with ventriculostomy. Now, the indication of emergency carotid endarterectomy and carotid angioplasty and stent. When clinical indicators and imaging suggest small infarct core with large territory at risk, compromised by inadequate flow from critical carotid stenosis or occlusion, or in the case of acute neurological deficit after carotid endarterectomy in which acute thrombosis of surgical site is suspected is not well established. Then role of antiplatelet. All the patient with ischemic stroke should receive aspirin within 24 to 48 hours of onset. The aspirin administration may be delayed by 24 hours in patients who receive intravenous thrombolysis. Administration of glycoprotein 2B3 inhibitors is harmful and it increases the risk of intracranial hemorrhage. Then clopidogrel in high-risk patient with acute non-disabling cerebrovascular event trial showed that short-term dual antiplatelet therapy with clopidogrel and aspirin for 21 days reduced the early secondary stroke without causing an increase in major bleeding. However, in recent trial, that is POINT trial, showed that dual antiplatelet therapy uh, new in patient with a new or minor stroke, we can go for the dual antiplatelet therapy. We can go for the treatment with the dual antiplatelet therapy. Thank you for paying attention.